So it's okay? All right.
Yeah.
Awesome. All right. Welcome to Grand Rounds. We wish you were here. We're handing out a new department lanyard that's going to be huge. We've got other versions coming, so don't worry if you missed it today. So I'd like to welcome to Zoom the resident applicants. I'll be speaking to you in a little bit. Hope you enjoy today's show. We do Grand Rounds a little differently here. Rather than an hour of somebody droning on, we only have 45 minutes of somebody droning on. And I do a little 5 minutes, and then River's going to do a little case presentation. So we pack a lot into an hour. Okay, it's freezing down here. My God, trick or treat last night. It took a little while to get going because it was also raining, really cold rain. And it's going to be cold this week, but for the applicants, normally it's beautiful around this time of year. Last night, of course, brought up the annual candy corn debate. Here we are, North Carolina, on the firmly hates candy corn sign. And I'd just like you all to know that candy corn hates you too. This is today's CME code, MAMHAR. Will didn't make these slides today, so that's why they look more made by me. So can everyone okay, someone's got something on in here that they shouldn't. Was it Chris? No. All right, we're good now. Was it Jim? Anyone holding a phone is presumed guilty. So for the faculty, everyone will soon get their clinical dashboard under a coded number. This is our initial attempt to get everyone data related to their clinic productivity. And then everyone will get their effort report, which is a distribution of how they spend their time and how it's paid for. We are not saying that this is correct data, but it's the data we have. And please get back to us about what we've got wrong, because this will be an important bit of information going forward. The first batch of PDC dissolution money, again, this is for the faculty, should be deposited into your accounts in November. This will be more than half the total, but we don't have an exact figure yet. And I remind you that the formula for this distribution is complex. And I don't know how much people are going to be getting, but just remember, some of it's going to be taxed at the bazillionaire rate, capital gains, 20% rather than income tax. So that's a big, hey, Kim, good to see you. The department's looking for a neurology APP lead with a list of duties. Anyone who's interested, email Megan Phillips, your CV in a one-page or one paragraph. Kevin Van Landingham. Mute, please. Okay, now I promised this last week. We're going to talk about what Durham County is and why it exists. Kaylee, you're talking. Please mute. Was that the right name? K-A-Y-L-I?
Yeah, sorry.
Okay. Because it puts your name up here if I hear you talking. So I know you. So counties are older than cities. They're less populous subdivisions. Cities grew up in them. There's one exception. The boroughs of New York are each counties, but they're within a city, so it gets complicated. We have 100 counties in North Carolina, 46 in South Carolina. 4 of them have overlapping names. So there's a Cherokee County, a Lee County, a Beaufort, and a Union County in each state. The most common names of counties in the United States start with Washington, Jefferson, and Franklin. And North Carolina has 1, 2, 3, 4, 5 of the top 7 as counties within North Carolina. Now, here's what we wanted to know. What is Durham City and Durham County? So until the 90s, the most important thing between the counties was there were different school systems in Durham City and Durham County. Now they're a merged thing. The most relevant difference is the taxes. So people in the counties pay different taxes because the counties have different responsibilities than the cities. So Durham County has 15% of the population of the combined. And its responsibilities are for the library, the elections, Superior Court, and jail. So even though the jail and the court are in downtown Durham, that is a county operation. The city controls the 911 system for the county, all the parks and rec, solid waste, so they're in charge of the people who come with those great trucks, all the city park and rec, recycling, stormwater, and the bus system. And importantly, there are two different police operations, both of which are fully licensed cops and can pull you over and give you a ticket and arrest you depending where you are. And they have different looking police cars. I think if we took a vote, we'd all agree that the city one, which is on the left, is a cooler looking car than the county. The county, they're called the sheriff. There have been several attempts to merge the city and the county, and they've all been defeated, both because the county often doesn't want to merge with the city, and the city says, we don't need the county. So it's off and off. So again, this is our CME code, and today's case presentation is Dr. River Jordan. And that is really his name, applicants. Okay, off you go.
See if I can pull this up.
Okay, now you gotta hit, go to share. You gotta go back out. Find Zoom. There you go. Share. And then pick yours. And now go with yours.
It is true.
Oh, and then just hide your meeting controls. Hide floating meeting controls.
Alrighty. Hello, everyone. I'm River Jordan. I'm one of the second-year residents. For the applicants, we always do these quick presentations. They're supposed to be really fun about an interesting case that we saw over the past year or two. So without further ado, my case is a case that I've been working on in medicine with Jenny Van Kirk. Let me see if
Just tap on the screen.
There we go. So today's case, we have a 32-year-old male. He has a past medical history of HIV that has since progressed to AIDS. He was first diagnosed at the age of 18. In the past, in 2019, he had 2 ring-enhancing lesions that were still to this day undiagnosed. He has something called HIV-associated neurocognitive disorder, which is known as HAND, and he was presenting for a severe headache and a rash. So just a timeline of everything that was happening. In 2019, he had those 2 ring-enhancing lesions. Every culture was negative. Every virus that we tested, fungus, everything was negative. They did a biopsy, questionable lymphoma, but the flow and the cytometry were all negative. So tissue biopsy was negative. He was lost to follow-up, intermittently followed with his medications and infectious disease. On the 1st of May, he came in, he had this diffuse rash all over his body. And the only thing that we were able to do was a punch biopsy per dermatology. But unfortunately, he keeps leaving AMA because he was just fearing the judgment that he would receive from his AIDS diagnosis. And then where I come into play is then on the 18th, he had a severe headache, 20 out of 10, partial vision loss, confusion, and ambulatory dysfunction, where he was now using a walker to walk around. The only thing we were able to grab was a CT head, which at the time the radiologist recommended an MRI for further follow-up and concern from the past lymphoma in the past. But again, he left AMA. And then on the 20th, he returned and he was eventually admitted to medicine. Just an overview of his physical exam that we saw here. His vitals, near septic appearing, general chronically ill appearing. On the left, we have this diffuse hyperpigmented macules and papules. He's really inattentive, unable to recall any words at 5 minutes, diffusely weak. He chronically had an HIV neuropathy, so it was length dependent throughout. And the only ambulation I can get was him poorly with a cane. But I relied heavily on his mother for any kind of information. And that was the left. And this rash on the left was everywhere on his body, face, back, everywhere. So what we did was this 2023 MRI, and it's really not all that impressive. Some leptomeningeal enhancement, some hyperintensities in the left basal ganglia there, and some hyperintensities that I put in the arrow in the left occipital lobe. But comparing that to his 2019 scan, you can see this left frontal lobe ring enhancing lesion that extended there. Interestingly, we didn't see that in the 2023 scan, and it looked like it was just encephalomalacia in that location at the time. But the meat of the conversation comes with his lab studies. Serum-wise, his HIV was out of control, very infectious. CD4 was less than 35. That's as low as our test can go here. In his serum, his CMV level was really elevated. Cryptococcus, toxoplasma were all negative. He did have a past history of syphilis, but this was a down titrated titer, so it was actually treated per ID. That skin biopsy that we did, it was negative for Kaposi sarcoma, but it was actually positive for CMV, which is incredibly rare. And then the CSF, not really anything too reactive. The CMV PCR was detected. Oh, I'm sorry. I don't think someone's muted. But the CMV PCR was detected in the CSF. JC cryptococcus was all negative along with the flow cytology and the cultures. So ultimately, we came to the conclusion, since this was a disseminated infection all over his body, his colon, his skin, now his CNS, we gave him the diagnosis of CMV encephalitis. And this was, again, a disseminated infection. So just a background on the cytomegalovirus. It is a herpes virus that's double-stranded DNA. Some studies document that the seroprevalence in the general population is ranging between 45 to 100%. So odds are everyone in this room probably has CMV, but it's kept at bay thanks to these T cells, CD4 and CD8, which keep it at bay in the CNS as well. Where it gets its name is that it creates these large intranuclear occlusions called owl's eyes. That's why it's called the cytomegalovirus. It makes cells big. And usually we see it in people that are immunosuppressed with CD4 counts less than 50, and it's extremely rare. The initial read on UpToDate says 2% of patients with AIDS have some kind of CMV detected, but that was even prior to our HIV antiviral therapies. Some findings that I saw, it was only 2% of patients with AIDS with the encephalitis, so 2% of those encephalitis cases. But it's so rare nowadays that I can't even find an accurate incidence on the number of cases of CMV encephalitis. And neurologic symptoms, typical encephalopathy, headaches, seizures, retinitis. Our patient only had the encephalopathy and the headaches. He did not have any seizures at this time. It's pretty rare to have a focal deficit with this condition. And it can also lead to a subacute progressive polyradiculomyelopathy, which we were questioning if that led to his gait impairment, but we also found a DVT in his left lower leg. So just some radiographic findings that we can see, nothing too specific, diffuse leptomeningeal enhancement, some ring enhancing lesions that we saw in my patient as well, but not too sure if the 2019 studies were the same. Some basal ganglia involvement, which we did see in our patient here, and some hyperintensities in the periventricular areas that I'm pointing out there. And these are not from the patient, these are from prior case studies that were similar. And then just overview of diagnosis and treatment. The most important is the CMV CSF PCR, which with the sensitivities and specificities listed there. We did get a CMV serum PCR, but this can be negative according to our infectious disease specialist here. Usually we see a lymphocytic pleocytosis, but I worry that this individual just had such progressed HIV that turned into AIDS that he couldn't really mount a reaction to it. The diagnosis is altogether a combination of things: the clinical syndrome, CMV, CSF, PCR being positive, and the radiographic findings that I discussed. Overall, for the therapy, it's very important that we catch this. The studies that I saw and the case studies that I saw, it's 100% fatal without any treatment. So I'm very happy this gentleman came back in. We started him on IV ganciclovir at that rate, switched him to PO, and most of his symptoms, if not all, resolved in about a week, actually. And then we're going to continue that until his CD4 count was greater than 100. Overall, for our case, he was lost to follow-up again, so I don't know where he is today. Key takeaways, though, he kept leaving AMA, so I just want to reiterate that patients with HIV and AIDS are heavily surrounded by stigma and the fear of judgment, and we really encouraged him to stay to get this week-long treatment. Always inquire about rashes in patients that have neurologic symptoms, as it can help broaden your differential. And remember, CMV encephalitis is extremely rare, and it carries a 100% mortality rate if left untreated. And that's it.
Hi, River. That was a beautiful job. And to the audience, we're hearing a lot of grunts and groans and maybe eating breakfast. Could everyone please make sure you're on mute? All right. And just for those in the audience, we're going to go 5 minutes over due to the fact that we started 5 minutes late. We're going to have to load the study right now. But today's presentation is by Dr. Jim Burke. We're still hearing people. Can you please check that you're on mute, everybody? Is Dr. Jim Burke, who you all know is a professor of neurology and ran our ADRC and our memory program for many years. and Kirby Gottschalk, who is an assistant professor of neurology and is also a longtime AD researcher. And they're going to talk to us today about metabolics, Alzheimer's disease, and the new GLP-1 drugs. So I'm going to invite Jim to come load the presentation, and we'll have like a 2-second break in the action. Let me just see who's not muted.
What is this?
Right here. So is everyone muted? Anyone see somebody who's not muted? Just yell it out. Okay, looks like we're good. Oh, it must be this person. No, I'm looking to, I mean, when I got COVID, I wanted to blame somebody and I couldn't figure out who to blame. So I'm looking to blame somebody for this too. As humans, we're always looking to attribute things. Oh, that's me. Oh. The wait for obesity treatment is over.
So while Richard is getting that started, I just wanted to give you kind of an overview of what we're going to talk about today. So obesity, as all of us know, has become an increasing problem in the United States and in the world over. But in addition to that, it has an impact on lots of other diseases. Obesity is a, excuse me, a major contributor to hypertension, diabetes, hyperlipidemia, stroke, cardiovascular disease, cerebrovascular disease. And our treatments to date have been singularly unsuccessful. It's been primarily behavioral modification, as well as low-calorie foods. And if you look at the success rate of that approach, it's probably less successful than treatment for alcoholism and other types of addiction. So we clearly need a new paradigm. Obesity's been known, excuse me, obesity's been known for at least 25,000 years. And there's a Venus of Willendorf statue that was circa 25,000 BCE, demonstrated a classic body type for someone with obesity. Hippocrates, as many other things, he led in terms of recognizing that it was a health issue and recommended diet, exercise, lifestyle, and use of emetics and cathartics. Not too different than what we were doing until very recently. Looking at obesity trends, what's happened in the world that has led to this incredible increase in obesity. If you look at the curve here, the surprising thing to me is that the number of people with overweight, the dark blue top line, has not really changed over time. Started to decline in recent years, but the amount of obesity in men and women and severe obesity has skyrocketed, and that is a major problem. There's been no country in the world that has had a decline in obesity prevalence since 1975. So something clearly is different. It's not genetics, whether it's the level of activity, the types of food, probably a combination. Just click on it. Okay. This is just a picture from 1990 to 2009 showing the rate of obesity across the country. On the left is 1990. You can see that the majority of the states had less than 10 or 10 to 14% obesity. By the year 2009, you can see that we're now talking about, especially in the Southeast, states with more than 30% obesity, and at least a quarter of the population being obese. So dramatic differences. And the impact of that in terms of diabetes, hypertension, is clearly developing. If you look at obesity is not evenly distributed across all populations. In fact, if you look at non-Hispanic Asians, the rate of obesity is actually quite low. Can somebody mute? And if you look at Hispanics and non-Hispanic Blacks, the rate is actually quite high. But across the board, we're looking at just an epidemic. As I said before, obesity does not travel alone. It also is associated, if you compare the obesity curves or the obesity graph with diabetes, hypertension, and stroke, you can see that where obesity is the most severe, you're also looking at the highest rates of those other disorders. And the hope is that by treating obesity, that you would mitigate the effects of those other disorders. Well, why haven't diets worked? There's a list here I could have taken thousands of things off the internet in terms of diets that have been recommended, but diets have not been successful. One part of that is that the average diet duration for women is 4 weeks, and for men it's 6 weeks. And for a chronic illness, that is clearly not going to be successful. If you look about 2 years after someone has been on a diet, 23% of people have more weight than they lost. If you look after 2 years, 83% gained more than they lost. In 5 years, 50% of dieters were at least 10 pounds over their initial weight. So diet clearly has been unsuccessful. Pharmacotherapy is not something that's new. In the 19th century, people were using extracts of thyroid in order to try to stimulate the metabolic rate. It was successful in causing weight loss, however, it came with a lot of side effects. Fat off was marketed for overweight and obesity. You could either put it in your bath, you could rub it on your body. Unfortunately, the ingredients were 10% soap and 90% water. And then there was Human Ease, which was certified or marketed as a cure for obesity and all known diseases. And that was found to consist of 95% lard. In the 40s and 50s, the prescription of amphetamines for weight loss was really common. In fact, Jackie Kennedy used amphetamines for many years for weight loss. Because of the problems with just treating people with amphetamines and sleep problems, they said, well, let's combine it with a barbiturate. And so they used pentobarbital or phenobarbital. And so that was kind of adding fuel to the fire. In the 70s, for people old enough, there was a great hope for the combination of phentermine and fenfluramine called fen-phen. And it resulted in a significant amount of weight loss over a period of over half a year. About 85,000 prescriptions a week were being written. The problem was that it caused a cardiac valvulopathy, and so that was essentially taken off the market. In the 90s, there was a drug called orlistat, which inhibited pancreatic lipase. It did result in some modest weight loss, however. They also told you not to wear white pants because it caused oily liquid stool. So that did not catch on. Bariatric surgery has been an option for a number of years. There's lots of different types of surgery. The problem is that if you look about 5 years after someone has had bariatric surgery, 15% of people, I'm sorry, 50% of people have had a 15% weight gain from their lowest point. And if you look at 7 years, about 25% have gained, 37% have gained 25% of their weight back. The change really occurred when liraglutide was published in the New England Journal, in which it showed that this GLP-1 agonist was able to result in a significant weight loss, as you can see in the curve there. The mean weight loss The mean weight of the people in the study was 106 kilograms. The mean BMI was 38. And after a year, the liraglutide group lost about 8.4 kilograms, about 20 pounds. 63% lost at least 5% of their body weight, and 33% lost at least 10%. So this was kind of fundamentally a success story, and it led to development of a lot of other GLPs in order to because this was an incredible market for pharmaceutical companies to get into. Okay, so I'm going to let Kirby talk about the mechanisms of action, and then back to
How do I advance this?
just your arrows up and down.
Yeah, okay, all right. Okay, just as a little bit of introduction, before I came to Duke, I was employed by GlaxoSmithKline in drug discovery and development. And, you know, obesity was an important target. I was primarily involved with diabetes research, and as I'll illustrate in a little bit, they kind of blend into each other. So this is the fundamental experiment that led to the discovery of GLP-1 and GIP, the incretins. I mean, it's a really beautiful experiment because it's so simple. It's comparing the insulin response to an oral glucose load versus a load introduced through IV. And you see that that the oral load results in a greater spike of insulin and a longer duration of elevated insulin versus the IV dose. Eventually, this was tracked down to the source of a hormone in L cells. And the hormone is the gene actually encodes glucagon, GIP, GLP-1, and a couple of other peptides. People since 1964 have been, you know, studying this field very intensely. I should say that exenatide was a long-lived analog of GLP-1. It's derived from Gila monster, and Lilly was using has used exenatide for diabetes purposes for quite a while. And in the preclinical studies in animal models and in the early human trials, it was noted already that treatment with exenatide resulted in lower amounts of food consumption and weight loss. In fact, some of the first clinical trials with semaglutide were conducted by John Buse, who got his degree here at Duke. He's now over at UNC running their diabetes program. And at the end of the paper, there was one little paragraph saying, pointing out that everybody who was on the drug lost weight, and they maintained the weight loss for as long as they were on the drug. So that was sort of the beginning. This graph shows a summary of the distribution of GLP-1 receptors in the body. They're widespread, but not universal. And I want to point out, well, I have to do this. Yeah, where's my pointer? Okay, so in yellow, these are different brain regions that you can see has the receptor, and heart clearly has receptor. Note that the kidney has receptor, but very low amounts, and of course the pancreas has quite a bit, and peripheral nerve also has quite a bit, The reason I pointed out the kidney was because there are recent headlines showing that Novo Nordisk just stopped a clinical trial on the efficacy of GLP-1 agonists for kidney disease, and they stopped it because it was so highly successful. They didn't need to continue it on any further. This graph sort of summarizes the effects of GLP-1 in a variety of different systems. So the effect is not just targeted to the digestive system. It's not just targeted to the brain. And all the systems that are illustrated here are responsive in every species that has been studied, from man to mouse to monkey to humans to rats and marmosets, I think, as well. Yeah, so the kidney effect is very pronounced, as I just indicated, and it's probably an indirect effect, though. And that's the take-home lesson from this, is that although the compound has effects on all these different tissues, not all these effects are direct. Many of them are indirect. This is sort of the intracellular signaling pathways modulated by GLP-1 agonists. The reason I bothered hand drawing this rather than clipping much more stylized pathways from journals is because I wanted to highlight the fact that, as I indicate here in red, there's overlap between the insulin signaling pathway, which hits AKT and also ERK, and also the GLP-1 receptor pathway, which hits ERK, and through ERK ultimately gets to the mitogenesis, Carol. That's very important. And but also the box items here, it increases autophagy, decreases oxidative stress, decreases apoptosis. Again, through the other arm, the ERK arm, decreases oxidative stress, increases autophagy. And a lot of the beneficial effects are due to the increased synthesis of FGF21 through the Krebs mediated cycle. So this illustrates the fact that although all those different endpoints are hit by the GLP-1 signaling pathway, not all cells, not all systems, not all tissues respond in exactly the same way. A lot of it depends on the dwell time of the agonist on the receptor, the turnover of the receptor, the covalent modification of the different signaling proteins. But it also illustrates the fact that because the agonist hits so many different pathways, it's not unusual, it's not unsuspected that you would see many different beneficial effects of the compounds. And the one question is, well, how does it regulate satiety? How does it regulate appetite? And the idea is, well, that GLP-1 binds to receptors in the pancreas, suppresses glucagon secretion, enhances insulin secretion. Now that lowers blood glucose as the first step. And then somehow it acts on the vagal afferents that go to the brain, and the brain then stimulate the PMC and CART neurons to reduce hunger. And they also stimulate the MPY and AGRP neurons to increase satiety. Now, by and large, everyone in the field suspects that this is because of GLP-1 acting in the periphery on the nerve, goes into the brain, hits GLP-1 containing nerves in the brain, and it releases a signal, and so that it's a closed loop. But that, in fact, probably may not be happening. GLP-1 is only released in very small amounts in the gut. It's turned over very rapidly because it's very sensitive to DPP-4. I mentioned earlier I was at GlaxoSmithKline, and one of our targets was inhibiting DPP-4, so we would extend the half-time of GLP-1.
Kirby, does the brain produce GLP-1, or does it get in the brain?
There are nerves that make GLP. I'll show you. There are nerves that make GLP-1, but it's like any other neurotransmitter. Transmitter rather. It's released locally. It acts locally.
So it doesn't get into the brain.
It doesn't. I'll get there.
But It doesn't seem.
Yeah, I'll show you. You're answering, it does not. Okay. Yeah, but you activate these pre-pro-glucagon containing receptors, which is the GLP-1 neurons in the brain, and that does reduce food intake, but you ablate those neurons and you diminish the amount of GLP-1 in the brain. It doesn't affect weight at all. So anyway, so the gut derived incretins probably act locally. You know, they go to the pancreas, as I indicated before. They modulate glucagon and insulin secretion, and they're turned over very rapidly. So it's not really clear how much of the GLP-1 released by the gut actually would get into the brain or stimulate the vagal nerve. Exogenous incretins, they don't really get into the brain. It's illustrated here. The type 2 diabetics taking this GLP-1 agonist for more than 5 months had CSF levels of 6.5 picomolar, whereas the plasma levels were 31 nanomolar. So it's probably not getting into the brain locally. And many of the GLP-1 agonists that are used commercially, well, first of all, the amino acid sequence is modified so that they're not susceptible to degradation by DPP4 or IDE. Secondly, they're modified by having fatty acids added to it, having amino acid sequences added to it. And some of those prevent them from getting past the blood-brain barrier into the brain. And the brain-derived, let me go back for a sec. I wanted to point out that exogenously administered incretins are neutralized only by antagonists that are introduced into the system peripherally, not centrally. And as I indicated, there are pre-pro-glucagon neurons in the brain that release GLP-1, but the effects of the central incretins are only blocked by antagonists that are added to the system centrally. So it appears that the central GLP-1 system, the peripheral GLP-1 system are acting independently of other, like two ships in the night. So I don't have a slide illustrating this, but Rich mentioned it in his introduction. GLP-1 agonists are being pursued as treatments for, as preventative treatments for Alzheimer's disease. And the effects on the cardiovascular system, the effects on kidney were discovered very, very early on in the course of preclinical workup of these compounds. The effects of the nerve on Alzheimer's were inferred by the fact that you have all these effects of GLP-1 agonists on inflammation, on apoptosis, on mitochondrial health. And there's a guy by the name of Holst, who's now working on it in China, who's really been pushing this very hard. And I have to say that the preclinical data that I've seen are promising, but they don't look any different than any other promising drug. They don't look any different than pioglitazone. They don't look any different than a lot of other compounds that you would use in mice. There have been a couple of phase 1 trials with Alzheimer's, and again, it's no different than the phase 1 trials with PIO, where you saw beneficial effects on one aspect of the disease, but they were not studied long enough to really look at cognition. So in other words, you see an effect on amyloid accumulation or glucose metabolism, but you don't really see an effect on cognition because they're not studied that long. Novo Nordisk has a phase 3 study right now, and is intended to report out in 2025. Notably, they didn't terminate it early for positive effects like they did the kidney study. So it's still ongoing. And I suspect that if you won't go beyond that. So I'm going to end my part with this conundrum. And I'm titled this a paradox of astrocyte GLP-1 signaling. So there are a number of individuals who have taken a look to see where GLP-1 receptors are in the brain, and they look at astrocytes and they see the sea of green for GFAP, and they see little speckles of yellow for GLP-1. And they say, well, there are no receptors in astrocytes, right? But this other group, Jen Brunning, took a look at the same micrographs, and he said, yeah, there really are GLP-1 agonists on astrocytes. And so he studied the knockout of the GLP-1 agonists specifically in astrocytes. And he's also done some comparable studies, not by knocking out, but by inactivating the receptor in culture. And so normally on the left, you see that GLP-1 maintains mitochondrial health, promotes fatty acid oxidation. Where's my point? Yeah, promotes fatty acid oxidation in red here, and it reduces glucose uptake by astrocytes here. So that's what GLP-1 does. That's kind of counterintuitive to what it does, what GLP-1 agonists do whole body. But then if you desensitize the GLP-1 receptor, or in his case, you knock it out entirely, well, now you don't have signaling to mitochondria. You have, it's a mildly impaired mitochondria function in terms of both oxidative phosphorylation, and in terms of what you see an increase in glycolysis in the animal in the brain. You see an increased fatty acid oxidation. You see decreased oxidative phosphorylation, but you also see an improvement, a significant improvement in glucose homeostasis. This is an oral glucose tolerance test. This is black. These are the control guys. Look, the glucose spike goes way up before it starts coming down. With an astrocyte knockout, it's prevented from going all the way up. And here's an insulin tolerance test. And again, the insulin doesn't plateau nearly as well in the controls as it does in the knockout animals. So, somehow knocking GLP-1 receptors out of astrocytes improves systemic glucose homeostasis. I don't understand why. This is hot off the press. This is a very recent paper, and I'm sure we'll be seeing more. Okay, I'm going to turn it back to Jim.
Thanks, Kirby. All right. So I showed you the data before Kirby started with weight loss with liraglutide. And that was just kind of a modest, demonstrated a modest benefit. What we have here is Wegovy, semaglutide. And this is a 68-week treatment phase. And you can see that the placebo weight loss is quite modest, 2% body weight. But you can see the treatment with semaglutide, 2.4 milligrams, resulted in up to almost 20% loss in body weight. Not everyone on the right-hand side lost weight, significant amounts of weight. There were people who lost more than 20% of their total body weight, but there were also people who lost much more modest effects. The important point about this curve, and the important point about these class of drugs, is that when the drugs are stopped, the effect goes away, not surprisingly. And in fact, we've heard a lot from people saying that the drugs are not particularly useful because they're going to have to be used long-term, that the cost of the drugs is so high that this is potentially a limiting factor. You can also see that whether you lost 20% of your body weight by the time you were out to 2 years, you were kind of continuing to gain weight. So it is true that if you are on one of these drugs and you stop, you are going to gain that weight back. The really encouraging thing about this class of drugs is that not only does it affect glucose and weight loss, but also on the upper left-hand panel, you can see that here's the effect of on systolic blood pressure. You can see that the effect is quite dramatic. And then again, when the drug is stopped, it goes away. Diastolic blood pressure, more modest, but again, has an improvement. Marker of inflammation, C-reactive protein, dramatically declines and has a slow recovery rate back to normal, and hemoglobin A1C. So if you were going to look at
weight loss, or is that
well, that's an interesting question, because is it weight loss that's causing it, or is it having and from what Kirby talked about, it has a potential for working on all these pathways. The fundamental thing, I guess, the take-home message is, if this drug actually works on, or these drugs actually work on all these different mechanisms, we talk about, we don't, when we think about treating hypertension, hyperlipidemia, fatty liver, risk factors for stroke and heart disease, we think nothing about putting somebody on a drug and saying that they're going to be on that drug for the rest of their lives. In fact, this could potentially have an effect so that either you could lessen the number of other drugs, or actually have kind of a one drug.
But at this point, it's not clear.
It's not clear what the mechanism is, and it's hard to disentangle, because if you're having the weight loss and your blood pressure improves, is it?
Although Kirby said there were a certain percentage of people who don't lose weight, so they have a blood pressure lower.
I don't know. Yeah, I don't think I haven't seen that published. So these drugs also work in people who've had bariatric surgery. You can see the curve here. This is with the older drug liraglutide. Here's the placebo, and you can see that people who did not lose weight on bariatric surgery or poor weight loss, if adding liraglutide did cause them to continue to lose weight. So even in the context of someone with bariatric surgery, it can be effective. It's also a paper that shows that in people on antidepressants, that it can help them lose weight. There was a recent paper, or actually it's not out yet, but Novo Nordisk has issued a press release that showed that for people who were in the weight loss trials, there was a 20% reduction in major cardiovascular events, which were stroke, non-fatal stroke, non-fatal myocardial infarction, or cardiac death. Also has an effect on, as Kirby was pointing out, on renal impairment. So these are people who had diabetes and chronic kidney disease, and the study was stopped by the Data Safety Monitoring Board because it showed that the people who were on drug had a lower rate of kidney function loss. So as with all drugs, there are side effects. They're mainly related to gastroparesis and biliary disease. You can see that the crude hazard ratios, biliary disease actually is not statistically significant as a hazard ratio. There is a risk of pancreatitis, but if you look at the incidence of pancreatitis, this is per 1,000 person years, you can see that the incidence of pancreatitis is relatively low. Gastroparesis is a very common symptom of people who are on drug complaining of early satiety. As you can imagine, there are lots of companies that are interested in using these drugs to selling these drugs to people. And this is just a comparison. On the left-hand side, there was a study of phentermine with topiramate, and you can see that there was about a 10% weight loss. Bupropion, naltrexone, about a 5% weight loss. Semaglutide had almost a 15% weight loss in one study, and similarly in another. And then one of the GLP-1 GIP drugs, tirzepatide, known as Mounjaro, actually has an even more powerful effect. So the drug that people are talking about quite often is Ozempic. Ozempic is the same drug as Wegovy. It's just a different dose. Novo Nordisk, who is a small Danish pharmaceutical company until these drugs came about. And now the value of Novo Nordisk is greater than the value of the entire Danish economy. So you can imagine that, and this is with limited access to the drugs. So it is something that has led to much hand-wringing about how can we afford to have these. But I think that the problem is that the focus has been on how about weight loss, as if this is just a cosmetic issue and not actually potentially impacting cardiovascular disease, renal disease. How many hospitalizations for cardiac stenting, or how many people on dialysis would you need to prevent in order to pay for the average annual cost of the drug of $13,000? And that, of course, is Scrooge McDuck diving into his money. In case you haven't looked at your supermarket news yet this week, the Walmart CEO said that Ozempic sales are, at least according to their early analysis, are actually impacting what people are buying in the grocery stores. What's not broken down yet is whether they're actually cutting back on some of the high carbohydrate, high sugar, high fat snack foods, or what type of food they're actually, and that'll be an interesting thing to see whether people actually are changing their dietary choices. Candy corn, plenty of candy corn. Well, if you look this week, I'm sure that's true. So knowing what the financial effects of these drugs are, you can imagine that everyone in the pharmaceutical industry is jumping in with both feet. Lilly bought a drug from Versanis, which is an antibody cutting fat while building muscle mass. Who could be against that? Novo Nordisk is acquiring Inversago, which is a drug that blocks cannabinoid receptors. They also bought Embark as an obesity drug that targets different undisclosed receptors. There are people looking at GLP-1 GIP agonists because of the effect of Mounjaro, which has shown better efficacy than just the GLP-1s alone. There's a triagonist from Eli Lilly. There's also a drug that is Boehringer Ingelheim is looking at to treat fatty liver as well as weight loss. So you can see that potentially these drugs have an impact across all of medicine, across all quality of life, and show incredible potential. So with that, I will ask if anybody has any questions.
So what's this got to do with Alzheimer's?
I didn't mention Alzheimer's. Yeah, I mean, if obesity is also a risk factor for Alzheimer's disease or through the lipid pathways, potentially it could have an effect. And as Kirby talked about, there are other ways as well. Did you want to?
Well, I will mention that several years ago now, in Journal of Clinical Investigation. Several years ago, in the Journal of Clinical Investigation, there were back-to-back papers. The first author on the first paper was Talbot, and the author on the second paper was Bromfin. Anyway, so they show that in brains of Alzheimer's patients, and also in a model of Alzheimer's, the tissue are insulin resistant, and you can actually take the tissue and expose them to insulin, and you find the insulin signaling pathways are wonderful in control tissue and really in Alzheimer's patients. And if you treat if you treat the mouse model, and I've forgotten which one it was now, and they were using semaglutide, which is one that does not get into the brain, those mice still had intact insulin signaling pathways in the brain. So now insulin signaling is a part of Alzheimer's, but it certainly isn't the whole schmear. But I think that it is indicative that other pathways like inflammation could also be playing a part. That's a long way of saying I really don't know the answer to your question.
Questions?
I was sort of thinking about the role of the drug the way that might affect Alzheimer's and the target population. It might affect Alzheimer's in that way, and the next people who are normal age, could that induce frailty? What are the long term?
Jim?
So the question was about whether long-term suppression of some of these pathways could have an effect, have long-term effects, and we don't know the answer to that. The drugs have just not been used for that long especially not in a non-diabetic population. At least in the diabetic population, you're normalizing glucose and hemoglobin A1C. In just the overweight population, the long-term consequences are not known. They could be positive, and the fact that suppressing inflammation over a lifetime could in fact result in less Alzheimer's disease or whatever the disease of choice is. On the other hand, it disrupting homeostasis, as we've known, as we've shown over and over again, we're not always smarter. We don't always know what to expect from the body when we make fundamental changes in signaling.
Jim, what is the data on midlife obesity and Alzheimer's risk 20 years later?
So it's the longitudinal studies that have been shown with are primarily that people who are obese have a greater risk of Alzheimer's disease
Or dementia.
primarily in people who are overweight in midlife. So if you're looking at people who get fat at older ages, it does not appear to have a significant risk. However, if you're overweight during midlife and then lose weight, the risk appears to be the early.
But is it due to the obesity or the comorbid conditions that come with the obesity? And is it due to a stroke rather than more amyloid? Does anyone have any idea?
There's not been any, and again, disentangling obesity with those other risk factors is just really hard.
I mean, there's just FYI, there's tons of studies saying this or that at midlife increases the risk of Alzheimer's, but what they're really talking about is dementia. The big issue is, does it affect the amyloid or tau part of the equation, or do you just throw a few strokes on top of a brain that's already diseased? And there's only been a single study ever that has shown that a midlife condition affects the amyloid part, and that's Rebecca Gottesman's study that showed obesity, high cholesterol, et cetera, at midlife increase the amount of amyloid you were destined to have when you turn 70 or 80. That was the only, and mostly in people who are E4. That's the only study I'm aware of that's ever shown that part of the equation to be, an effect.
Is anyone ever worried about phospho-tau? I mean, I see amyloid, but what has happened to the phospho-tau in this thing?
So the question is, what about phospho-tau? I don't know of any studies that have looked at tau.
Well, I mean, in terms of human or in terms of
Humans.
preclinical models?
Well,
Humans?
yeah, I mean, actually,
No,
I'm
it's-
interested in mouse data.
Who cares about
I know.
They're mice.
Never mind. Oh, let's
Yeah.
go to the group.
So no one's looked, right? I mean, it's just,
Nobody has any idea.
No.
So Rebecca was able to do amyloid just because she got a grant to do 500 amyloid PETs. It's much harder to convince people to get us a spinal tap. Yeah.
Well, now that there's peripheral biomarkers, I mean, it's becoming more trivial to do that. So I think that certainly is something that there's certainly a focus on using biomarkers, peripheral and central biomarkers, and measuring them in every context. So I'm sure that'll be in the works.
And anyone needs to go can go, but Jim, do you want to just comment on the Tomorrow study and Alan Rose's thought about this kind of way to prevent Alzheimer's disease?
So the Tomorrow study was a study of pioglitazone, low-dose pioglitazone, in cognitively normal people who were at risk for developing Alzheimer's based on genetics, mainly ApoE. The study, as from what Kirby was talking about, the pathways can lead to Alzheimer's disease pathology, and so the study was a longitudinal study. Unfortunately, it was stopped prior to completion, partially for a lack of efficacy. There's some politics in there that I won't go into, but it unfortunately was stopped before it could really be demonstrated whether there was an effect or not.
But the point being that Alan Rose at his heart believed that Alzheimer's was a metabolic disorder related to similar pathways, and so there's ample reason to think that these things are related. Anyway, thanks to our two presenters and to everyone who's here. Thanks, Kirby. Thanks, Jim.
Okay, you're welcome. No Alzheimer's.
So the idea behind it that the drug is change the peripheral stuff and that'll have a secondary effect in the brain.
That's certainly, I think inflammation data is really interesting, and also the metabolic. You could actually affect glucose, cholesterol, inflammation, can affect mitochondria.
For those things that Rebecca, a lot of the stuff Rebecca looked at, Burke didn't know. But I think there's no reason. The problem with the Tomorrow study is Alan Rose used this ridiculously low dose.
Yeah,
These new drugs much more powerful. But sounds like it's like midlife, you hit that, and then you go. It's going to be incredibly expensive.
But did people who's on overlap with GLP in terms of things they do?
Yeah, I mean, you could see through the cyclic
Kirby
pathway.
studies, the slide. I started texting. But there is overlap.
Yeah, oh, absolutely.
So there were only 2 studies in clinical trials for GLP-1 agonists. One was in England, one was in Denmark.
They're planning a big one.
They- Well,
I mean,
both of these were starting in
Hey.
2014.
But we have a meeting with them to discuss it. So I mean, they're planning a big study.
That's good.
That's
That's really
good.
interesting.
Me too.
It's
Good way to get it
troublesome
free.
though. I don't understand
No, but
how
like
one
one of our
metabolic
residents,
pathway is really
like
being
River doesn't
counterworked.
know.
I mean, it
Very
seems.
Yeah, well, it's
When
yeah.
our
I mean, when it does
residents-
everything, it's really hard
I
to
know,
figure
I
out
know,
whether.
and that
Think of, like,
seems to me
adding
to
more
be,
aspirin, but they don't
you know,
think of
not a good
adding
approach
something
to
like
the
this.
disease process.
Which would
Well, it's kind
really
of going
be
back
right
to the
thing.
old
But-
approach of having
I
a mixture
agree.
of chemicals and you
Everything.
throw it in
Throw
there,
it
and then, you know, what the
And
hell
if you
was that?
survive, great.
Yeah. Well, you know what they used to use for weight loss was DNP, dinitrophenol,
Oh, my
and they
God.
shut off.
Yeah.
They
Yeah.
should, you know,
Yeah, one
the
day
Krebs
we'll be-
cycle. You don't
We
need
have
the
no
Krebs
energy.
cycle.
We're just a little tired, that's all. If that's what's
Swelling
happening
and
to me.
bleeding. The side effect in this one is you're gonna look great. Whereas with, an anti-amyloid antibody, you got the swelling and bleeding.
Oh,
Yeah.
the
Yeah.
Ozempic
Yeah, but
face.
maybe they really need to go back
You know
to
what Ozempic
how
is? It's
again?
losing weight.
They
I
need,
take Ozempic.
they need to go back to
It's
looking at
amazing.
how.
It's just amazing.
So how does it compare to metformin?
where they showed.
In terms of weight loss.
Metformin, yeah, I don't need metformin. My sugar is great, my cholesterol's great. I just need to lose weight. I pay cash for it, and it's well worth it.
There you go.
How much is a couple $100 a month?
No, it's $1,000 a month.
We'll sit.
Okay.
I'm already off one of my blood
Couldn't miss it.
Okay.
Today's John's birthday.
Oh,
I was
okay.
just like, I gotta go to Burke, my son.
Yeah. I
Really?
I gotta go.
So that's
Thanks, I
Great.
appreciate it.
Decrease the blood pressure.
Yeah, well, I'm all fun
Good to
now.
see
I
you.
got my
Good to
HCG
see
and I
you.
got my M-Lotus.
I had a picture of him as a slide, but I took it out. I figured that was
I don't
blow
keep
the
it
bar across his face.
Well, great job.
They're remarkable.
Thank you.
And every bit as remarkable as the injection. The
Oh,
injections
that's
are
cool.
remarkable.
That is very cool.
Oh, yes, perfect. Okay.
Yeah.
Sounds good.
I think they're
Well, that's-
remarkable.
That's interesting.
Oh, there were a lot of.
Good job, Kirby. That was exactly what I was hoping for.
That's good, Kirby. A lot of metabolism. Your slide there looked like, didn't we all have that? Burger
Burger,
man
yeah.
high, yeah, that thing we used to have to show we were like scientists. Anyway, I think it's amazing.
Oh, most of us will be on it before long.
Well, the question is, you got to get on it early. Don't
Yeah.
wait. But you look like you've lost a ton of weight, Jim.
I've lost